Frozen shoulder is not, as the name might suggest, a concept where the shoulder joint freezes due to cold. Frozen shoulder starts with pain and eventually results in restricted active shoulder movements and limited passive movements during examination, impacting daily activities and overall shoulder function. The shoulder is the joint of the body with the greatest range of motion. On the one hand, it needs to be secure enough not to be pushed to its limits, and on the other hand, it needs to have a joint capsule that is loose enough to allow all this range of motion. For some unknown reason, an inflammatory process starts in the joint capsule surrounding the shoulder joint. This capsule then hardens and loses its flexibility. This inflammation in the shoulder joint capsule initially causes an increase in the number of connective tissue cells here. Then, these cells begin to act like smooth muscle cells, contracting and resulting in the shortening and hardening of the joint capsule. This whole process is completed over a period of many months. When the process is complete, the elasticity of the joint capsule is restored, or the capsule may have shortened and the volume of the joint may have decreased. In both cases, however, the pain is usually completely resolved. In the first stage, although the joint has full range of motion, it starts with pain, especially at night. This pain may be severe enough to disrupt the patient's daily life and sleep patterns. In the second stage, the pain is accompanied by limitation of movement. In the third stage, the volume of the joint capsule has decreased, the joint has stiffened, movements are restricted, but the pain has also decreased. Sometimes, however, the limitation of joint movement may completely resolve. In other words, there is not only pain but also restriction of movement. The most commonly affected movement in the arm is the outward rotation of the arm. Patients have difficulty raising their hands to their heads to wash their hair. Especially female patients in particular report difficulty reaching their backs to fasten their bras. X-rays are completely normal at every stage of the disease. Even in MRI reports, everything is often reported as normal. Although thickening of the capsule may occasionally be noticeable on MRI, there is usually no tear in the shoulder tendons or any additional pathology causing pain. Moreover, it is not a rare condition at all. It occurs in a considerably high proportion of the population, between 2 and 5%. It is more common in women and in people with diabetes. In one academic study, the rate in non-diabetics was 1.5%, while in diabetics it was reported to be 13%, and in some publications, up to 30% of diabetics were reported to have frozen shoulder. The likelihood of a diabetic patient developing frozen shoulder throughout his or her life is between 10% and 20%. In diabetic patients, it often occurs at a younger age compared to non-diabetics. It is more commonly seen in those who have had diabetes for a longer duration and in those with poor blood sugar control. But there is no information that it is more common in insulin users. It is very rare to see it in people under 40. It is mostly observed between the ages of 40 and 60. It is also not commonly expected in those over 70. Once it has fully healed, it is extremely rare for it to recur in the same shoulder. However, it can appear in the other shoulder in about 20% of patients. Additionally, if one identical twin develops it, the other is 2 to 3 times more likely to develop it compared to the general population, indicating a genetic predisposition. Furthermore, frozen shoulder is more commonly seen in cases of hyperthyroidism, where thyroid function is overactive. Previous surgeries on the shoulder, breast, or cervical spine can trigger the condition. For instance, about 10% of patients who undergo breast cancer surgery develop frozen shoulder. 5 to 11% of those who have had shoulder surgery before develop frozen shoulder. Also, in those who have a trauma in the shoulder region, injury and bleeding in this region can cause frozen shoulder by initiating the process that shortens the shoulder capsule. In fact, the process can last up to 2 years in most patients, with or without treatment. In most cases, there is a significant improvement in movement restriction by the end of the process, allowing patients to perform daily activities. However, in 7 to 15% of patients, the movement restriction remains significant and permanent. They struggle to raise their hands to their heads, to wash their hair, and to reach their backs. Although the pain is expected to completely resolve by the end of the process, some patients may continue to experience persistent pain. Be sure that the process takes really a long time. Our goal is to ensure that the process is smooth and painless, and to prevent any movement restrictions in the end. The treatment varies depending on the stage of the disease. Physical therapy, which will start in the early stage without restricting shoulder movements, ensures that shoulder movements are preserved at the end of this process. In the last stage, when the joint is completely stiff, physical therapy will no longer be of any benefit, so it is strongly recommended to start exercises in this painful period before the shoulder movements are completely stiff. At this stage, oral anti-inflammatory drugs or intramuscular cortisone injections can reduce pain and facilitate the application of physical therapy. However, it is well known that these medications have their own specific problems. Instead, greater benefits can be achieved with lower doses of medication through cortisone injections directly into the joint, administered by an orthopedic or physical therapy physician. Moreover, this method is less harmful and advantageous for patient compliance, making it our preferred choice. Cortisone injection into the joint causes a significant reduction in pain for 6 weeks. If necessary, several injections can be given at 6-week intervals. Instead of physical therapy alone, it is more effective if it is combined with medication and injection. An alternative treatment method for diabetic patients who are not suitable for cortisone injection is ESWT. ESWT is a method of breaking kidney stones with ultrasonic sound waves applied by urologists from outside the body. Forcing the movement limits of the joint by injecting pressurized fluid into the joint under anesthesia may improve the shoulder movements of patients in the early stages. However, in the long term, it has been shown that it does not give a different result than intra-articular cortisone injection. Another treatment method is intra-articular injection of cortisone and hyaluronic acid together, followed by physical therapy. Hyaluronic acid has long been a safe application, injected as a fluid into the knee joint for osteoarthritis. 90% of these patients improve significantly with non-surgical methods. I would like to remind you that these processes will take a long time. By long, I mean that if there is no improvement with physical therapy and joint injections within 9 to 12 months, in that case, surgery becomes an alternative to consider for patients. In surgery, arthroscopy, as a minimally invasive method, involves using small entry points and a camera to expand the joint capsule all around. With this video, I tried to give you information about frozen shoulder. Don't forget to subscribe not to miss my videos on orthopedics, nutrition, and sports, and don't forget to like for support. May you have active days where you always smile and do not have health problems.